My name is Jeff Bohr. I'm professor of medicine, cell biology, radiology, and surgery at the State University of New York in New York City. Today I spoke about drug therapy for primary heart valve disease for outcome improvement. The sum and substance of the presentation was that there are no drugs that have been demonstrated rigorously to improve outcome in patients with primary heart valve disease. There have been a number of studies, but they're largely observational, epidemiological, retrospective, not randomized controlled trials, which are absolutely necessary to be able to show that an intervention is better than no intervention. The best example of why that's so important is the area of aortic stenosis, where for years there were epidemiological studies that showed that aortic stenosis was associated with hypercholesterolemia, that patients whose cholesterol was lower had less rapid progression of aortic stenosis, etc. It seemed obvious that the thing to do was to treat patients with aortic stenosis with statin drugs in order to slow the progression and prevent the adverse outcomes of aortic stenosis. But 4 large placebo-controlled trials now have been done, and none of them showed any benefit from statin therapy. It seems that the point is well made that randomized controlled prospective trials are necessary rather than inferences from observational studies. In aortic stenosis, there are other ways to theoretically slow the rate of progression by preventing calcification. For example, bisphosphonates. In a small randomized study, it was shown that bisphosphonates were able to reduce the degree of calcification rate progression in aortic stenosis. No randomized controlled outcome trials have been done, but a large observational study was done in 800 women that showed absolutely no effect of bisphosphonates on aortic valve area progression, and no effect at all on clinical outcomes. Hypertension is an important concomitant of aortic stenosis because it adds to the outflow obstruction of the stenotic valve itself. It used to be feared that treating patients with antihypertensive drugs if they had aortic stenosis was dangerous. That's been disproven many times now. The benefit, however, of reducing hypertension, of reducing blood pressure in patients who have hypertension in addition to aortic stenosis, hasn't been demonstrated. The closest we've come so far is a large observational study in which 1/3 of the patients serendipitously received angiotensin converting enzyme inhibitors or angiotensin receptor blockers, and 2/3 didn't. And those who received the drugs over time had better outcomes than those who didn't receive the drugs. But again, non-randomized. You really can't use a study like that as a basis for mandating therapy in patients with aortic stenosis. Aortic regurgitation, the same thing. It seems fairly obvious that vasodilating drugs should reduce aortic regurgitation and improve outcome. There are many studies that show that short-term administration of vasodilating drugs do reduce aortic regurgitation. The question is, do they do it sufficiently to improve outcome, and is the reduction maintained over time? And the answer is no. In an observational study that we did several years ago, we found that the patients who received vasodilating drugs progressed to an endpoint, that is death or heart failure, at a rate of about 17% per year, whereas those without the vasodilating drugs progressed at a rate of about 4% per year. So people did better without the drugs than with them, and there are theoretical reasons why that might be so. However, that was not a randomized trial. A randomized trial subsequently was done, where 95 patients were randomized to no treatment, to an angiotensin an angiotensin-converting enzyme inhibitor, enalapril, or to a long-acting calcium channel blocker, nifedipine, dihydropyridine calcium channel blocker, which is a direct vasodilator. The three groups were followed over time, and in fact, the patients in the control group who got no drug progressed to an endpoint at a rate of about 4% per year, which is expected from epidemiological studies. The patients who received nifedipine absolutely were spot on with the control patients. There was no effect at all. The patients who received the angiotensin-converting enzyme inhibitor, however, did 20% worse. So, that's consistent with our observational study, very much unexpected. The defining characteristic of that population, though, was that it was normotensive. What if you have hypertension? Hypertension is not good in aortic regurgitation. We and others have shown that hypertension increases risk in patients with aortic regurgitation. So what if you treat a hypertensive population with an antihypertensive drug? And that was done twice in randomized controlled trials. And lo and behold, nifedipine, long-acting nifedipine, that did nothing in the normotensive population, improved outcomes in the hypertensive population, who also had aortic regurgitation. Doesn't seem like it does much for the aortic regurgitation, but it does do something for the hypertension. Mitral regurgitation, virtually no data at all. There are no randomized controlled trials using vasodilators, although many clinicians use them in patients with mitral regurgitation based on no evidence. We published an observational study last year showing that patients who received vasodilating drugs actually did no better than patients who didn't receive vasodilating drugs, except in a very small subset of patients who had hypertension, too small a group to be able to draw firm conclusions. It looked as if the patients who received the vasodilators who had hypertension did better than the patients who received the vasodilators who didn't have hypertension. Don't know what that means. Finally, there are no data in patients with mitral stenosis or tricuspid regurgitation. So to summarize, we have very few data, very, very few based on randomized controlled trials. The data we do have are based on observational studies, so firm conclusions can't be drawn. And I think the summary statement would be, we have no evidence for treating patients with primary valve disease with drugs to improve their outcomes.